Welcome to the Committee on Health and Human Services. Would the Secretary please call the roll?
Assemblywoman Gonzalez. Here. Assemblywoman Gorlow. Here. Assemblyman Gray. Assemblyman Hafen. Here. Assemblyman Hibbets. Assemblyman Koenig. Here. Assemblywoman Newby. Here. Assemblyman Wynn. Here. Assemblyman Orentlicker. Here. Assemblywoman Taylor. Assemblywoman Thomas. Here. Chair Peters.
And I am here. I believe our missing members are presenting bills, so we'll mark them present when they arrive. Thank you, everyone, for being here. We appreciate you. Before we begin, I'd like to make a couple of housekeeping items. Please remember to silence your phones and your devices so we're not interrupting each other. Members of the public may testify in a variety of ways, all of which are listed on the agenda. You may also submit public comment in writing, either in addition to testifying or in lieu thereof. Written public comment may be submitted before, during, or up to 24 hours after meeting adjournment. If you wish to testify in person, please sign in at the table by the door and leave a business card. If you do not testify, you may also want to sign in so we have a record of who's interested in particular bills in the event that we need to get a hold of you. To ensure an orderly flow of discussion, all comments, questions, and responses must go through me. And committee members, please remember that you should be recognized by me before you can speak. Additionally, I ask presenters on Zoom video calls to leave your cameras off and microphones muted unless it's your turn to present or if I direct any questions to you. When testifying in person, please turn the microphone on to speak and off to listen so we can avoid that nasty reverb. With that, we'll move on to our agenda. What is not on our agenda is a bill introduction, but this is the same as all our bill introductions. It does not obligate you to the bill, but it allows us to introduce the bill on the floor. I would entertain a motion. Oh, I'm so sorry. I didn't tell you what the BDR was. Y'all, for the record, the BDR is 40-1057, which revises provisions governing halfway houses for persons recovering from alcohol or other substance use disorders. I would now entertain a motion. Thank you, Assemblywoman Gonzalez, and a second from Assemblyman Wynn. Is there any discussion or comment on the motion? Seeing none, all those in favor, please signify by saying aye. Aye. Any opposed, nay? The motion passes with those present. Thank you so much. We are going to can't remember the order of my agenda. We're going to go in order on the agenda today. We have Assemblyman Watts who's here to present Assembly Bill 263, which enacts provisions relating to the transmission of Legionnaire's disease by building water systems in certain healthcare facilities. Thank you so much for being here. It's great to see you.
Thank you very much, Madam Chair. It's good to be here, I think, in Health and Human Services, definitely for the first time this session. For the record, my name is Howard Watts. I have the pleasure of representing Assembly District 15 in the heart of Clark County, and it's my pleasure to present Assembly Bill 263 for your consideration today, again, which is aimed at reducing the transmission of Legionnaire's disease, particularly among vulnerable populations in healthcare facilities. Joining me to help present the bill today, we have providing neutral expert testimony about Legionnaire's disease. We have Brian Labus with the UNLV School of Public Health down in Southern Nevada. We then have joining us by Zoom Scott Hamilton, the Senior Director of ASSE International, and I'm joined by Greg Esposito with the Nevada State Pipe Trades. So we're going to get right into it. I'm going to turn it over to Mr. Labus to provide a high-level overview of kind of the issues that we're seeking to address, and then we'll take it from there. And after everyone's finished, we'll be glad to answer any questions that the committee may have.
Thank you. Thank you, Madam Chairwoman and members of the committee. I'm Brian Labus. I'm an infectious disease epidemiologist and assistant professor of epidemiology and biostatistics at the UNLV School of Public Health. In 1976, there was this respiratory disease outbreak in Philadelphia of a new disease we hadn't seen before, resulted in 200 cases and 34 deaths during that outbreak. This was our first experience with what we would come to know as Legionnaire's disease. It was named after the fact that it was at the American Legion Convention. And it took some time to really figure out what was going on. But over the next 50 years, we were able to come up with ways to identify the bacteria responsible for the disease. We could then test patients for it, test the environment, and as a result, we were able to treat patients and remediate the environment. And most importantly, we were able to find ways to prevent this disease. Now, unfortunately, in that 50 years, we've also seen cases and outbreaks of this disease all over the country and all over the world, including here in Nevada. Most recently, there was an outbreak on the Strip earlier this month. It's not something that is common by any means, but it's also not something that's completely rare. So, what is Legionnaire's disease? Well, it's a respiratory infection that causes a high fever, a cough, shortness of breath, muscle ache, and a headache. And then for most patients, it progresses to a pneumonia, fluid in the lungs that makes it very difficult to breathe. 95% of the people infected with this disease wind up being hospitalized for it. And about 1 out of 8 people who get this disease ultimately die from it. The rate is actually 1 in 4 when you look at patients who acquire it in a healthcare facility. So if you have somebody who already has underlying health problems and they get this disease on top of it, the death rate is very high from this. 80% of the cases are in people older than 50 years of age, and 60% of the cases we see nationwide are in men. We also see higher risk of disease with people that have underlying lung problems. So smokers, people with diseases like emphysema or chronic obstructive pulmonary disease, or those who have weakened immune systems, either because of medications that they're on or health problems such as cancer or diabetes. People in those groups are at higher risk of infection, and as a result, there's a higher risk of disease and death in that particular population. In 2022, there were 43 cases in Nevada, which doesn't sound like much, but the problem is this disease is vastly underreported. It's not something that is hard to identify if you're looking for it, but routine clinical testing doesn't regularly identify this disease. So you really have to be thinking that it's Legionnaire's and run the appropriate test to find it, and most times people are just diagnosed with some sort of pneumonia, they get treated with antibiotics, they get better, and they never really figure out what it is. That is why we are concerned about this disease. Every case we find is the tip of the iceberg. NAC 441A 580 actually says that 2 cases that are connected to each other is sufficient to define an outbreak. We recognize that there are a lot of cases that we miss, and so the numbers that we see really do not tell the true story of what's going on. The other problem we have is that hotel casino outbreaks tend to grab the headlines. That also gives us a misleading picture of this disease. If you look nationwide, about 15% of all Legionnaire's cases identified are associated with travel, typical stays in hotels, not just in Las Vegas or Reno, but around the country. But 20% of the cases, more than we see with the travel, are associated with healthcare, either hospitals or long-term care facilities. And like I said before, the death rate of cases acquired in those places is double that we see just in general for this particular disease. So where does this organism come from? Well, it's something that's in the environment everywhere. We can find it all around us all the time. If some of you go home and test your faucets, you may find this organism. Now, that doesn't mean that you're going to be at risk for disease. The problem is when the organism gets a foothold, it can multiply and get to levels that can actually lead to disease. So when you go and turn the shower on, that water comes through the pipe, kicks up whatever bacteria is there, and aerosolizes it, and you breathe it in. And that's how you wind up being infected with this. We see it from things like swimming pools, decorative fountains, cooling towers, misters, hot tubs, but also the potable water system itself. We also have issues potentially with HVAC systems, depending on how they're designed. That's the way the outbreak in Philadelphia in 1976 actually occurred. It was the water that was being used as part of the air conditioning system. The big challenge for us here in Nevada is the temperature of water. Legionella does best between 77 and 108 degrees. We don't run our hot water systems usually hot enough to be above that because it's kind of dangerous. You turn on the tap and you don't want somebody to get burned. But in the summertime, it's also difficult to get cold water out of your tap. Everything is warmer here when you're in the middle of a desert. So that winds up being one big challenge for this particular disease that sometimes can be a little more of an issue in Nevada, but it really is an issue nationwide. The good news is this disease is preventable. Prompt identification of cases and investigation of those cases and clusters allows us to prevent additional people from getting sick. But what we ultimately want to do is prevent that disease in the first place. And that comes down to those environmental and mechanical systems that we use in our buildings to get us water, to keep us comfortable. And it's the proper design and installation and maintenance of those systems that are necessary to prevent this particular disease. In most places, it requires putting in some sort of comprehensive water management program that involves not only the appropriate design of these systems, but regular testing and maintenance of the systems to ensure that they function the way that they were actually designed. Those programs need to follow national standards, which are well developed. They're used throughout the country that allow us to prevent these sort of things at all types of buildings. And that regular maintenance and testing allows us to quickly identify problems and remediate them in the facilities. And that's what the bill that's in front of you today is talking about, these types of water management programs that go toward preventing disease before it would ever occur, especially in the high-risk settings such as healthcare facilities, where we know we have people that have underlying health problems that lead to greater risk of infection and, unfortunately, greater risk of death. So, thank you.
Thank you very much. So, Madam Chair, I think next we'll move to Mr. Hamilton on Zoom to provide some additional detail. But again, I very much appreciate Mr. Labus providing that overview. And this bill aims to take a first step at trying to eliminate Legionnaire's disease by focusing on those vulnerable populations in healthcare facilities. So with that, we can turn it over to Mr. Hamilton.
Good afternoon. Can you hear me?
We can. Welcome, Mr. Hamilton.
Thank you. Good afternoon, Chair Peters and members of the committee. My name again is Scott Hamilton. I'm here today representing ASSC International to testify on AB 263. As the committee deliberates this important legislation, I wish to serve as a technical resource to answer any questions that you may have. AB 263 pertains to the health and safety of the immunocompromised, the healthcare workers, facility visitors, and also the workers performing the water quality tasks. For context and background, the organization I am representing, ASSC International, is a renowned ANSI-accredited standards development organization in the mechanical and plumbing industries that have been providing technical assistance to model code bodies and governments since 1906. ASSC has developed standards and certification programs which have been adopted by facilities for decades, such as the ASSC 6000 for medical gas installation and the ASSC 5000 backflow testing and repair. ASSC's water quality expertise has been utilized extensively by numerous state and local governments, including those in New Jersey, due to the high quality of standards it publishes. Along with industry, ASSC developed the ASSC 12,000 certifications in response to the growing threats to U.S. water quality that have been emerging in recent years. The legislation before you today seeks to include the ASSC 12,000 certification in order to reduce the presence of Legionella. On June 2nd, 2017, the Centers for Medicare and Medicaid Services released a mandate requiring that all certified Medicare and Medicaid facilities have water management plans that meet ASHRAE 188 industry standards to reduce the risk of Legionella. The ASHRAE 188 standard provides minimum Legionella risk management strategies for the design, construction, commissioning, operation, maintenance, repair, replacement, and expansion of new and existing buildings and their associated pipe systems and components. Basically, the standard informs the facility what should be done. The Centers for Disease Control and Prevention, otherwise known as CDC, produced a toolkit for building owners and facility managers. The CDC toolkit aims to provide an easy-to-understand interpretation of ASHRAE Standard 188 to help building owners and managers evaluate the water systems and devices in their buildings to see if they need a program and then develop an effective water management program. All mechanical, fire protection, and potable water systems are required to be mapped, assessed, monitored, controlled, verified, and documented to ensure compliance. Again, the CDC toolkit informs the facility what should be done. ASHRAE 188 offers an integral part of the solution needed to protect water safety by establishing vital criteria and procedures to combat Legionella risk. However, an additional component is needed in this strategy, a requirement that such program be administered by persons with requisite technical qualifications to do this work properly. This is essential given the highly complex and challenging nature of modern water systems and the lethal threat posed by Legionella. In 2018, the industry approached ASSE, and together, through the open consensus ANSI accredited process, the ASSE Series 12,000 Water Management and Infection Control Risk Assessment for Building Systems was developed. This standard was developed to cover all water quality issues, including chemicals, metals, and bacteria like Legionella. The design and implementation of Water Management Plan, or WMP, under ASHRAE 188 involves highly complex, sophisticated operations. Specifically, the development of a reliable water management plan requires in-depth knowledge of all water structures and systems, as well as specialized skills required for building surveys, including sampling procedures, detection of hazardous conditions, system monitoring, and incident response. In addition, persons responsible for these programs must have sufficient training needed to identify, assess, and prioritize water quality risks wherever they may exist in a given system. They must also possess requisite expertise and skills for implementing corrective actions and control measures when hazardous conditions are found, and have the capabilities to modify piping, fixtures, or other system components to prevent hazardous conditions from occurring in the first place. Unless clear qualifications standards are established for persons responsible for water management plans, these programs can easily fail or have only marginal impact, results which are unacceptable when battling a fatal disease. Unfortunately, one can find examples of Legionella and other bacterial outbreaks which may have been avoided utilizing individuals certified to ASSE 12,000 and water management teams. One example I want to share with the committee is an incident that took place in a nursing home in western Wisconsin. The facility had been in operation for years. In 2020, residents of the facility contracted Legionella. Due to limited resources, they called their local mechanical contractor. Fortunately, that contractor and its employees were certified to the ASSE Water Quality Standards Series 12,000. Because that type of facility cannot evacuate its residents, the contractor, through training, knew the most effective way to stop the spread. These ASSE certified professionals installed point-of-use filters on all potential harmful outlets, as well as tested various parts of the facility to identify infected locations, and also began investigation. It is important not only to mitigate the bacteria, but also know the reason for its growth. They found that the maintenance personnel, in attempts to save energy and costs, shut down the hot water recirculating pump at night when everyone was sleeping and turned it back on in the morning. It was determined that this was the action that allowed for Legionella growth. The contractor worked with the facility to mitigate the bacteria, set up a management plan, which included sampling and testing. The last example I'd like to share was again in 2020 at Brigham and Women's Hospital in Boston, where the facility saw a number of infections and subsequently 3 patients' deaths from bacteria. The hospital sampled cultures from sinks, showers of each of the rooms occupied by the patients, but the bacteria levels were non-existent or too low, ruling out as a likely source. Experts did find high levels of bacteria from ice and water machine samples on the cardiac surgery intensive care unit. Records show that the machines have been cleaned and maintained properly. But further testing unveiled that the chlorine levels in the problematic units were undetectable due to a commercial water purification system the hospital had installed in the plumbing lines leading to these units. The filter included a carbon filter and a UV irradiation unit, both of which decreased chlorination concentrations. These systems was designed to improve the taste, odor, and purity of the water, but allow bacteria normally killed off by chlorine to proliferate. In closing, there's no question that ASHRAE 188 is viewed as the gold standard for water quality management. ASSE recognized this and, with industry, categorically designed the ASSE 12,000 series to establish appropriate skill standards for persons responsible for implementing water management plans under ASHRAE 188. ASHRAE 188 and ASSE 12,000 are both vital to securing safe water quality and protecting public safety. Contractors and technicians install, maintain, and service the facility water systems. With the training and ASSE 12,000 certification, they can play a vital role on the facility's water management team and provide the technicians the tools necessary to incorporate the facility's water management plan. I want to thank you for the opportunity to provide comment, and I'm available to answer any questions you may have. Thank you.
Thank you, and if it's all right with the chair, I'd turn it over to Mr. Esposito to walk through the sections of the bill.
The amendment?
Yes, I would direct everyone's attention to the amendment. There's some significant streamlining of the language, so that's what Mr. Esposito will be going through.
Yes, please proceed.
Thank you, Madam Chair, members of the committee. Greg Esposito, representing the Nevada State Pipe Trades. Truly appreciate your time this afternoon. To go through the bill, sections 2 through 8 are definitions. Section 4 has some heavy, has a lot of strike-throughs where they
Wait,
specify.
can I stop you for just a quick second? I just want to make sure everyone has access to the amendment. I'm seeing it on Nellis. Please let me know if you're having trouble seeing it on them. We're seeing it? Sorry. Mr. Haven? We're good? Okay, sorry. Please proceed. Thank you.
Once again, Greg Esposito for the record. Section 4 has eliminates the calling out of different systems. Section 5 talks about where immunocompromised people might be. And it does call out some very specific conditions and diseases that we feel are important to leave in, because that is the intent of the bill is to make sure all patients at hospitals are safe. And we've added subsection 4, which is intended to include senior living facilities, because as you heard earlier, they are at high risk of contracting Legionnaire's disease if their water systems are infected. Section 9 is actually the meat and the real intent of the bill, and I won't go through line by line, but what Section 9 says is that a healthcare facility has to have a person on their water management team that has certified in the ASSE 1260 or 12,060 and 12,080. That results in about 28 hours worth of training. And it doesn't have to be per facility. It just calls out that a healthcare facility has to have a team in place, basically a person who knows what they're doing. So that's really the true intent, meat and potatoes of this bill. Further on in Section 9, more or less all of subsection 3 is crossed out. It was where we had detailed where the sampling needs to happen. It was redundant because ASHRAE 188 is already in place, and then all of Section 10 is eliminated regarding cooling towers, because once again all of that is covered in ASHRAE 188. Then sections 11, 12, and 13 are reporting requirements. As you heard from the good doctor down south, a lot of Legionnaire's cases are underreported. And so 11, 12, and 13 sort of create some standards where if a healthcare facility does find that there's an outbreak, they need to report it to the State Board of Health. Section 14 it talks about what the penalty is for not following this standard. And then probably the most important part of this bill, the most important change, is a January 1st, 2025 implementation date, 18 months after the end of this legislative session. And the reason we changed that is to give plenty of time for the ramp up for the training to be put into place, the training to be spread throughout Nevada. This way, people who are qualified can get the training they need and meet the obligations of the law. So that's a walk through the bill. Everyone who has testified is available to answer any questions you may have.
Thank you. I have a couple questions from committee members. Assemblyman Nguyen, would you like to start? No, okay, sorry, no, my confusion. Assemblyman Hafen, please go ahead.
Thank you, Madam Chair, and I do have a number of questions, and so I may ask a couple now, and then we'll circle back if they don't get addressed by others. I appreciate the presentation today, and I believe we started out saying that this problem arose in 1976 in Pennsylvania at a facility, and so my understanding is that after that, the CDC and CMS have put into place requirements for these healthcare facilities now to address the Legionnaire disease, including the water management plans that you guys are talking about in here, and testing and all that sort of stuff. And so I'm curious, is it that we don't trust the CDC, or are we trying to address a different problem?
Thank you for that question. Through you, Madam Chair, to Assemblyman Hafen, Howard Watts for the record. I think at its core what this is trying to do is, and I think this was mentioned by Mr. Hamilton during his presentation, there are standards that have been adopted by CMS for what has to be done. But one of the things that has now recently been adopted is certification to make sure that the expertise is in place for individuals developing that, so that there's a plan. It has to have certain things, but you heard about some of the complexities that can come up in some of these water systems. So even though there may in general be a plan, there's been some recent cases where despite that there have still been outbreaks, and so this makes sure that somebody has the training to really thoroughly identify and mitigate potential risks to be involved in developing that plan. So in short, yes, we do trust the framework that's been adopted for the what. This addresses the who in terms of making sure that extensive training and expertise is going into the development of those plans.
And then just right along with that, and then I'll let everybody else go. So as you guys know, I'm a licensed water operator in the state of Nevada, go through the whole certification process. And so I'm curious why we're coming up with a new process for testing and everything else when it comes to water quality, rather than just adopting the current standards and training that we currently have in statute for these additional facilities.
Thank you. Through you, Madam Chair, to the
Or you
Assemblyman.
can go directly to the members. Thank you.
Howard Watts for the record. I'll ask Mr. Hamilton to provide some additional context, but again, I think it's important to differentiate between the standards for what has to happen and the standards, the training for who we would have doing it. But Mr. Hamilton, would you like to provide some additional context?
Yes, thank you. Again, Scott Hamilton from ASSC International. Again, just to recap everything, CDC, again, writes down things that are never really mandatory. ASHRAE created and developed 188, again, for the healthcare facility. Actually, it's for any facility except for single family residential, to help them mitigate the risks of Legionella. But it tells you what has to be done, what should be done. And it leaves it up to the facilities then to incorporate it, and with the resources that they may have on hand, do the best they can with what they do. And basically, if you want to break ASHRAE 188 down to the simplest terms, it says you have to have a water management team. It could be one person, it could be 10 people, it could be 100 people, but you have to have a team. And you have to have a program in place. That program could be, I test the water once a year. That's it. That's all our resources allows. So again, we're still seeing, the problem is ASHRAE 188 is great. The testing procedures that we have are good, but we need another person, the people that actually work on these systems, that install these systems, that service these systems, that maintain these systems, that know that when you change these systems, there's a reaction that can take place downstream, and what that reaction is. Now, unfortunately, the plumbers and everybody else that install these systems, they don't have that type of training. They're not familiar with ASHRAE 188 and everything else that goes beyond it. And with the ASSC 12,000, again, we go beyond Legionella. We also cover lead and PFAs, PFOs in the training and in the certification. So that's why the industry came to ASSC. ASSC didn't develop it on their own. The industry came and said, look, there's a gap here between ASHRAE 188 and us that are installing and maintaining these systems and the training that we have, that we've had for hundreds of years. We need some kind of extra training and some kind of certification to prove to the end user, to the facilities, that these people that are coming to work on your water management teams have the working knowledge to be able to protect the occupants of that building. No different than in the 90s when the hospitals, well, let's put it this way, NFPA 99 was the how to install medical gas systems. But up until the mid 1990s, there were a lot of cross connections, a lot of people getting seriously hurt or dying from improper med gas installations. The industry at that point in time said, we don't have the training here. They came to ASSC and said, can you develop the ASSC 6000 for med gas installers? Since then, you see those numbers really drop off to next to nothing. And in fact, those that have had incidents are using people that aren't certified and trained. So we're hoping, by looking at still the numbers of the Legionella cases that take place in nursing homes and in hospitals, ASHRAE 188 is in place, the other water management teams in place, but there's still a piece missing because you still have these outbreaks. And the industry felt that the piece missing is having the contractor and the technicians that are trained and certified that can help out, that can assist on the water management teams and provide possible solutions on how to not just test and sample. That's the easy part of it, but how to understand where the bacteria may be growing and why it may be growing, and stop it from occurring before it actually occurs. If they do what they're supposed to do, then the sampling and testing are going to show negative every single time because they're on top of their game on the first part of the system. Sampling and testing just validates that everything they're doing is working. So I hope that answers the question.
Thank you so much. I have Assemblywoman Thomas next. Sorry.
Thank you, Madam Chair. And good afternoon, everyone. And thank you for the presentation. And thank you for this legislation that I think is really, really important for our community, for the simple reason that especially if we're going to use it in nursing homes. This is a community that cannot help itself, and for us to do anything to help them, this is really, really great. But I do have questions regarding Section 9, subsection 4B. And, I've heard, standards and pieces that are missing, and I'm looking at the stopgap measures that actually can be attained in this. Because when I look at line 7, where it goes to maintain records of the water management program and all sampling details and results for at least 3 years, such records must be made available for inspection by the board or health authority upon request. That troubles me, upon request, because, if you have a team that's looking at your water treatment plant and you're measuring, you're going after to see if any bacteria is growing and the Legionella, if you want to see if that's in your system, if you're not recording that on a continuous basis, like once a month, however the standards tell you to do, and recording it, and you're allowing the facility, quote unquote, manager to say in a report, yes, I did this, or yes, this was done, I don't believe that's a good stopgap measure, because then you have to rely whether or not this is actually happening, or are we, padding the books, so to speak.
Thank you very much for that question, Assemblywoman. Howard Watts for the record. I appreciate that. One of the things, again, is that we're trying to make sure that the data is available. One of the things that I will note is that in Section 11 of the bill, if there is a positive test, that has to be reported immediately. And so that is a requirement that would trigger getting the health authorities involved and kind of proactively checking out the rest of the records. And again, one of the things that we're trying to do is balance this with the amount of the length of time that records need to be kept, and also not necessarily inundating the health agencies with a lot of negative test results, but making sure that that is there. And then, to your point, if something happens to pop up, that will trigger a look back, and if there's any discrepancies or missing records, then that's cause to potentially trigger some of the penalties that are included in the bill. And the goal, I think, kind of to what Mr. Hamilton discussed with medical gases, is that once we have this whole picture together and this entire framework set up, just one of those incidences is probably going to be enough to show that that anyone who tries to kind of skirt the intent of the law is going to end up in trouble if something were to happen. So that's kind of the way the information reporting is envisioned.
I appreciate your answer, thank you. But I would hope that you would look at it again and consider the stopgap measure, because it's something that's so important to the community that you're trying to serve. And if you don't have something in there in the beginning, and you're saying you're going to have it at the end if something happens, how do you measure something that happened in the beginning? It could go months, even years, and then you get a positive, and you have no data to back you up. That's all I'm saying. But thank you anyway.
Thank you for that. Howard Watts for the record. The other thing I should mention is that this then, based on the capacity of the different health care agencies, the whole purpose of the upon request, that would allow random kind of audits or inspections to go to facilities and say, hey, we'd like to see your records and what you're doing. And again, that's a scenario where everything could totally be above board, but if somebody's not keeping up with the testing and the water management plan outlined in the bill, that's how it would be caught.
Thank you. I have Assemblywoman Newby next.
Thank you, Madam Chairwoman, and thank you, Assemblyman Watts, for bringing this. My question is actually for Dr. Brian Labus. Obviously, we've talked about the
Mr. Labus, or Dr. Labus, would you please keep the microphone turned off? We get a really bad reverb up here from it. Thank you.
We've talked about the deaths that have resulted from Legionnaire's disease in some of these facilities, but what I'd like to know is what are some of the symptoms of this disease, and what happens when someone contracts it who maybe doesn't die, but are there long-term effects of it? Thank you.
For the record, Brian Labus, thank you for that question. The disease for most people, it takes a while for them to recover. So it's not like you get the flu and you're better a week later. People can have all sorts of issues that go on for months till they really get over this, because this is really quite a debilitating illness when they have it. For the people in healthcare facilities, you're talking about somebody who's being treated for, maybe they had heart surgery or something like that, or they're being treated for cancer, and then we add this on top of it. So it's really hard to say what those long-term effects are, because you're taking medically fragile people and adding a bad disease on top of it. So it's one of those things where it can be months before a person really feels back to normal, just because it can take so long to recover from it. It's not something that's known to cause disease for the rest of your life. It's not like we talk about long COVID or something like that, where a couple years later people are still dealing with it. Once you get over it, you can kind of go back to normal, but it is a pretty debilitating disease to have, because it's just pneumonia, you can't really breathe, and it takes quite a while to get over it.
I had a similar question related to the exposure. Can you talk a little bit about, like, what is the exposure effect? Is it acute? Is it long-term exposure? At what concentrations are we concerned about? The bacteria? Should discuss a little bit of that.
Sure, I'd be happy to. Brian Labus for the record. Basically, within a couple weeks of being exposed, you will get sick. That's why we see so many travel-associated cases. It's people who visit a hotel, stay there for a couple of nights, and they're exposed to the disease in that situation. So for hospital stays, it doesn't have to be a very long stay. You could be in there overnight, and that would be a sufficient exposure for you to actually get sick. It really comes down to the concentration of the bacteria in the pipes that's getting kicked into the air. So if you have a small exposure, it may not be enough to cause disease, but a large enough exposure, even a single exposure, is enough to make somebody sick. So this isn't a chronic buildup of a problem over time. It's really an acute exposure. People get an acute disease. Think of it like COVID or flu or a lot of these other infectious diseases we deal with. You get exposed and you get sick. The difference is Legionella doesn't spread from person to person. It's always an environmental exposure. So you can treat Legionella patients and it's not going to put you at risk of disease. But if the problem is in their room to begin with, you're going in there and breathing that same air, you would be exposed to that environmental source just like the patients were.
Thank you so much. Assemblyman Gray.
Thank you, Madam Chair. Well, you guys are making my mind work hard today and think back. Thank you, Mr. Esposito, for coming up by my office and discussing this. I appreciate that. One of the things that you guys jarred my mind here a few minutes ago was when you mentioned that the most recent outbreak was down on the Strip. And prior to that, I was looking at this more as a nosocomial infection until I remembered, no, this is, if I'm not mistaken, this is a headwaters issue or a source water issue. And I'm wondering why you guys are attacking it at the hospital or the facility as opposed to going to where the disease is coming from and preventing it from getting into the entire water system to begin with.
This is Howard Watts for the record. One of the things I will say is that we have some pretty high quality, particularly in southern Nevada and in our urban communities, some pretty rigorous water treatment standards. But again, as was noted, there, those chlorine and some of those other disinfectants can break down over time. The water can sit there over time. There might be other filtration systems at different points along the distribution path that remove some of those things. So my understanding is that a lot of at least our major water systems are putting out water that is not is free of that bacteria, but it's then as it gets further along the pathway and gets into some of these situations where it no longer, it sits there and allows that bacteria to grow. And so, and again, we've really wanted to focus this on, where we think some of the most vulnerable people are, where getting this could have extremely serious repercussions as kind of the first area that we want to hone in trying to address this issue. And again, I just want to note really quickly before we move forward that we've been in conversations with different healthcare facilities and providers to listen to their concerns. Those conversations are ongoing, and we certainly appreciate their feedback.
Thank you.
Thank you. Other questions? Seeing none, we'll move into testimony. Thank you so much. We will start with support testimony in our physical locations and then move to phones. I would start here in Carson City for support testimony on Assembly Bill 263 and invite those who would like to testify to the table. Let's keep those seats rotating. There'll be musical chairs for a little while here. Please remember to state your name for the record. If you are in the physical locations, you don't necessarily have to spell your name because we should have it. But on the phones, I will ask you to spell your name. You may begin when you're ready.
Madam Chair, members of the committee, good afternoon. For the record, my name is Mandy Wilkins, and I am the Executive Vice President of the Mechanical Contractors Association in Las Vegas and the sheet metal and air conditioning contractors in Southern Nevada. It is not lost on me that it is Friday afternoon in Carson City, and this committee has two more bills. So with that, I will be exceptionally brief, and I'm here to lend our support to the amended version of this bill. So thank you very much.
Thank you. Please go ahead.
For the record, my name is Mark Ellis. I'm with Communication Workers of America, Local 9413. First, good to see you again, Madam Chair. I haven't seen you in a while. And on behalf of our close to 700 members that work at St. Mary's Hospital and our retirees, we are in full support of this bill.
Thank you.
Thank you, Chairwoman Peters and the members as well. For the record, my name is Susie Martinez, and I am the Executive Secretary Treasurer of the Nevada State AFL-CIO. And on behalf of over 150,000 members and 120 unions, we are in full support of Assembly Bill 263. It is vital that we take measured steps to ensure that our healthcare facilities are safe. A healthcare facility is not only where people receive the care and attention that they need, but also a workplace for thousands of people across the state. Stronger regulations concerning water management plants will not only ensure that patients are protected, but that the healthcare workers are safe in their day-to-day jobs. I would like to thank Assemblyman Watts for bringing this bill forward, and I urge the committee to please support Assembly Bill 263. Thank you.
Thank you. Please go ahead.
Good afternoon, Chair, members of the committee. My name is Fran Alvarez. I am here today as the president of the Nevada Silver-Haired Legislative Forum. We meet to discuss issues that affect seniors. This issue affects seniors, and I ask for your support on this bill. Seniors are very vulnerable, and this disease is deadly to them. Please think about how this bill will help them in their, they have other issues, and this disease makes those other issues that they have deadly. So please, I ask your support for this bill. Thank you.
Thank you. Please go ahead.
My name is Matt Leiden. I'm the business manager of Plumbers and Pipe Fitters, Local 525, and the president of the Nevada State Pipe Trades. We stand in support of this. We appreciate your consideration, and thank you.
Thank you. Please go ahead.
Madam Chair, committee members, my name is Alfonso Lopez. I represent the sheet metal workers and rail transportation workers of Southern Nevada, and we also are here stand in full support with this bill. Thank you.
Thank you. Are there other folks in Carson City who'd like to testify in support? Seeing none, we'll move to Las Vegas. If you are there to testify in support of Assembly Bill 263, please come up to the desk. Remember to state your name for the record. You may begin.
Hi. Good morning, Chairman Peterson, a member of the committee. For the records, my name is Eduardo Zavala. I represent the Bricklayers Union in Nevada. I'm here in full support of Assembly Bill 263, and I urge the committee to support it as well.
Thank you. Is there anyone else in Las Vegas who'd like to provide support testimony? Seeing none, BPS, is there anyone on the public line who would like to provide support testimony on Assembly Bill 263?
To testify in support of Assembly Bill 263, please press star 9 to take your place in the queue.
Good morning, Chairwoman Peters and members of the committee. For the record, this is Liz Sorensen with the Nevada State AFL-CIO. I'm here in full support of Assembly Bill AB 263, and I urge the committee to support the bill as well. Thank you so much.
Thank you. Next caller, please.
Good afternoon, Chairwoman Peters and the members of the committee. For the record, my name is Sue Bird, S-U-E-E-I-R-D, and I am here in full support of Assembly Bill 263, and I urge the committee to please support this bill as well. I support this legislation because it will keep both patients and healthcare workers safe by implementing stricter regulations to prevent the spread of Legionnaire's disease and possibly some other ones. As I am fully aware, in my 7th decade, others in my same age group make up a large portion of hospital beds, and I am more susceptible to diseases of my lungs And if I lose my lungs, I'm not able to keep myself as healthy as I would like to be. So please support this bill and protect our seniors. And thank you, Assembly Watts, for bringing it forward. It is very important to be preventative for our health. Thank you again.
Thank you for your testimony. Please add the next caller.
Good afternoon, Chair and members of the committee. My name is Paul Catha, that's spelled C-A-T-H-A, and I represent the Culinary Workers Union Local 226. We support AB 263, and we urge the committee to support and pass the bill as well. Thank you for your time, and have a good day.
Thank you for your testimony. Next caller, please. BPS, are there additional callers for support testimony on Assembly Bill 263?
Caller with the last number 788, you are unmuted and may begin.
Good afternoon, Chairwoman Peters and members of the committee. For the record, my name is Rita Weishar. It's spelled R-I-T-A, capital W-E-I-S-S-H-A-A-R. I'm with the Nevada Alliance for Retired Americans. I'm in full support of Assembly Bill 263, and I urge the committee to support it as well. Thank you.
Thank you. Are there additional callers on the public line for support testimony?
If you have recently joined and would like to testify in support of Assembly Bill 263, please press star 9 to take your place in the queue.
Good afternoon, committee chair and members of the committee. My name is Marlene Lockard, representing SEIU 1107, and we are in support of AB 263 and urge your support. Thank you.
Thank you. Are there other callers in support?
Chair, there are no other callers to testify in support at this time.
Thank you so much. We'll go ahead and move into opposition testimony in our physical locations. If you'd like to testify in opposition to Assembly Bill 263, please come up to the tables and we will get started. Please remember to state your name for the record. You may begin when you're ready.
Thank you, Madam Chair, members of the committee. Joan Hall, representing the Nevada Rural Hospital Partners. I appreciate Mr. Esposito talking with me yesterday and giving me a draft of the amendments. That gave us a little better feeling. However, our members' safety is very important. We have water management teams. Not sure that any of our members meet this criteria for certification that are on our teams. I've looked at that, and I think in the rural areas that just may be a little difficult. So I look forward to working with Mr. Esposito to look for solutions. Thank you.
Thank you, Madam Chair, members of the committee. For the record, Jessica Ferrato here today on behalf of Fresenius Medical Care. In opposition, respectful opposition to the bill, I just wanted to start out by talking a little bit about dialysis patients. Patients in dialysis clinics have low exposure to Legionnaires due to the process in place and the minimum hours that they're in a clinic. Most patients are in clinics 3 to 4 hours a day and not for 24-hour periods. In addition, they're there 3 to 4 days a week. Dialysis requires heavy use of water. Fresenius clinics have very elaborate water cleaning systems done by their certified biomedical teams and filtration systems that provide the quality and safety required for these treatments. Renal dialysis facilities are included in the ASHRA 188 standard, which is referenced throughout this bill. These standards are already factored into all of our facilities, and as our facilities are set up, certified ASHRA employees build the facility when first purchased and rented, as well as review and maintenance done on a regular basis in the facilities. Fresenius also follows recommendations by the CDC Legionella Toolkit as well. This bill would create an onerous program for each one of our facilities to have to implement and monitor on an ongoing basis. Our number one priority is patient care and safety, and we provide critical care for our patients. Dialysis facilities are complying with safety standards and mitigating the already low risk for our patients and our facilities. Thank you.
Thank you. Please go ahead when you're ready.
Thank you, Madam Chair and members of the committee. For the record, Chris Ferrari. On behalf of DaVita, also here in respectful opposition, want to thank the sponsor and the proponents for communicating with us on this matter, and we're continuing these conversations. DaVita serves nearly 3,000 Nevadans through its 49 clinics statewide. We go into rural areas as well, including Churchill, Elko, Humboldt, Nye, and White Pine counties. Based on our review of AB 263 as amended, the version we're all looking at today, we just want to put on the record that we may seek an exemption as it appears that the medical water system in use at our dialysis facilities already meets or exceeds what is contained in the bill. Also, on the record, just so you know, we don't have showers and there's nothing overnight. I know a couple of those were mentioned during proponent testimony. In dialysis, as Jessica indicated, water quality is critical. So we're very much in support of water quality, especially when it comes to treating those most vulnerable. In doing so, there are very precise specifications that must be met. I'm going to attempt to garble through these terms, but the systems we use in our outpatient clinics are designed and maintained to provide a chemical and microbial quality defined in AAMI ISO 23500. AAMI is the Association for the Advancement of Medical Instrumentation. This certification is sanctioned by the FDA, CMS, and CDC to define the physical quality and quality monitoring required to provide hemodialysis treatments for the U.S. end-stage renal disease population. So again, we're in gentle opposition. We'll continue to work with the sponsor and proponents, and appreciate the committee's time today. Thank you.
Thank you. Please go ahead.
Thank you, Madam Chair and members of the committee. Brian Evans here representing the Nevada Healthcare Association. The Nevada Healthcare Association represents assisted living and skilled nursing facilities throughout the state. I don't want to belabor the point too much on this, and we thank the sponsor for working with us and hearing some of our concerns. I just want to state one fact, about 20 cases a year in Clark County and 1 case a year in Washoe County is the average from all reported cases, not just medical facilities. So I just want to put that out there, showing that it's not as high as we would think, but it is something that we are definitely supportive of and want to make sure that our water systems are safe. But just wanted to let everyone know that that's the amount of cases that we see on average in the state of Nevada. Thank you.
Thank you. Are there other people in opposition in Carson City? Seeing none, are there folks in Las Vegas who would like to provide opposition testimony on Assembly Bill 263? Seeing none, BPS, would you check the public lines for opposition testimony on Assembly Bill 263?
To testify in opposition to Assembly Bill 263, please press star 9 to take your place in the queue. Chair, there are no callers to testify in opposition at this time.
Thank you. We'll move into neutral testimony in our physical locations. If you are here in Carson City or Las Vegas for neutral testimony, please come up to the desk. Seeing none in either Carson City or Las Vegas, BPS, would you check the public line for neutral testimony on Assembly Bill 263?
To testify neutral for Assembly Bill 263, please press star 9 to take your place in the queue. Chair, there are no callers to testify in neutral at this time.
Thank you so much. I would ask the bill sponsor if they have closing remarks. Waiving closing remarks. Thank you so much. We'll go ahead and close the hearing on Assembly Bill 263. Thank you so much. It was a pleasure to have you in HHS for maybe the first and only time this session. We're going to go ahead and move into our next bill, Assembly Bill 277. We will open the hearing for Assembly Bill 277, which establishes provisions governing rural emergency hospitals. Our very own Assemblyman Koenig will be presenting today. Please state your name for the record. You may begin when you're ready.
Thank you, Chair. We'll keep this brief.
Thank you, Chair Peters and committee members. My name is Greg Koenig, representing Assembly District 38, which includes all of Churchill, Esmeralda, Mineral, big parts of Lyon, and Nye. I'm pleased to come before you today to present AB 277, which is seeking to establish rural emergency hospitals in our state. It is an honor to be able to discuss a topic that is close to my heart and of great importance to our healthcare landscape. The struggles of rural hospitals in Nevada and across the country, and how the establishment of a new Medicaid provider type, the rural emergency hospital, can make a difference in providing essential health care in underserved rural areas. Rural hospitals in Nevada and throughout the nation are facing a crisis. In recent years, many of these facilities have been struggling to maintain their operations and to meet the needs of their community. The consequences of these struggles is far-reaching. When rural hospitals close, communities lose access to essential healthcare services such as emergency care, primary care, and behavioral health services. This can lead to long travel times to access care, worsening health outcomes, and the exacerbation of existing disparities in health equity between rural and urban Nevada. It is a domino effect that impacts the entire community, from the families that rely on these hospitals for care to the healthcare professionals that lose their jobs and the local economies that suffer. Recognizing the urgent needs to address this crisis, the Center for Medicare and Medicaid Services has created a new type of provider type, the Rural Emergency Hospital, which is available since the beginning of January of this year. This innovative concept aims to support rural health care by creating specialized hospital type that caters to the unique needs of rural communities. According to CMS, the designation may help certain rural hospitals to avert potential closures and to continue to provide essential services to the communities they serve. Rural emergency hospitals focus on providing access to emergency services, observation care, and additional medical and outpatient services. These facilities can help bridge the gap in healthcare in rural areas. Implementing this new provider type will require the support and collaboration of various stakeholders, including us policymakers. We must work together to create an environment that enables the success of rural emergency hospitals, ensuring that they receive the resources and recognition that they need to thrive. We, the legislature, can further contribute by authorizing Nevada Medicaid to seek additional federal funds to increase reimbursement rates for rural emergency hospitals. With that, Chair Peters, I'd like to turn the time over to Blaine Osborne from Nevada Rural Hospital Partners to explain the bill.
Please go ahead.
Thank you, Chair Peters, members of the committee. Blaine Osborne, Nevada Rural Hospital Partners, for the record. And I want to thank you for hearing AB 277 today, and thank Assemblyman Koenig for sponsoring the bill, and for all of you that have signed on to it as well. This is an exciting bill for us because, as you heard, this is a brand new type of hospital designation from CMS. And this is an instance where Nevada gets to be proactive and not getting behind the 8 ball. This is a new tool in the toolbox to keep rural hospitals open and in their communities. We've provided the committee with a Medicare Learning Network fact sheet on what rural emergency hospitals are. You're going to hear me refer to rural emergency hospital as REH because it's a little bit shorter, and that's been uploaded on Nellis. And I just want to stress a couple of points on what an REH is. First, an REH is not a freestanding emergency department, and we're not going to have REHs popping up all across the state. To become an REH, you have to already be licensed as a critical access hospital or a small rural hospital with fewer than 50 beds. In total, we only have 13 of those in the state who could qualify for this. If you're one of those hospitals and you're struggling financially to stay open, or if you simply don't have enough inpatient admissions, this lets you close your inpatient unit and keep your hospital open. That means you must keep your emergency department and your outpatient services like lab and imaging, and you can keep any distinct part units like long-term care, psych, or rehab. You must meet all the same kind of conditions of participation, including having a transfer agreement in effect with trauma centers. You have to meet certain staffing requirements, meet certain quality measures, etc. On the bottom of this page, on the fact sheet, it discusses meeting certain licensure requirements, including being located in a state that provides for licensing for such hospitals under state or local law, licensed under such law, and approved by the state or local agency as meeting the standards for such license. That's what we're trying to do with AB 277. Even though this designation just went live this January 2023, 2 months ago, 7 states have already passed similar bills licensing REHs, and the NCSL has a great webpage with links to all of those laws. Each year, we typically have about 25% of our critical access hospitals operating in the red. And although no rural hospitals have closed in Nevada since 2015 when Tonopah closed, this is a really wonderful option in comparison to closing your hospital. We've all seen the devastation that can occur when a hospital is forced to close. This has the ability to keep hospitals open and operating in our rural communities. With that, I appreciate your consideration of AB 277 and would happily take any questions.
If I may, real quick, it's not a 100% fact, but I talked to some people from Tonopah that feel that if this was in place in 2015 when they had to shut down, mostly for financial reasons, that they would still be up and running today if this was in place at that time.
Thank you for the presentation. Are there questions from the committee? Assemblyman Gray.
Thank you, Madam Chair. Just out of curiosity, it will not encourage some of these hospitals to, they're in the red to close down, will it? Okay, that's a little concerning. I mean, I like the idea. I love the idea, and thank you guys for bringing this. I'm just still a little concerned that there may be a dearth of other specialties.
Yeah, absolutely. Thank you for that question. Blaine Osborne, Nevada Rural Hospital Partners, for the record, and through you, Madam Chair, to the Assemblyman.
Feel free to go directly to the member. Thank you.
That's a great question, and no, that is not a situation that any of our rural hospitals want to find themselves in. Again, this is another option just to be able to keep your hospital open.
So yeah, Assemblyman Gray, I think instead of encouraging them to close, this is a mechanism to help them be able to stay open.
Thank you.
And that was Assemblyman Koenig for the record there. I have Assemblywoman Newby, please.
Thank you, Madam Chairwoman, and thank you, Assemblyman Koenig, for bringing this bill. I think it's a great idea. And so my question was, when you spoke of this allowing the inpatient beds to close, I was curious, is that considered a permanent closure or a temporary one? Is it something where if you didn't have any patients, you could close it for a week or a period of time, and then somebody comes in and needs that, you open it back up? Thank you.
Sure. Thank you for that question. Blaine Osborne, Nevada Rural Hospital Partners, for the record. Yes, that is a more permanent closure than a temporary one. However, CMS does have a process in place that if the hospital finances improved, they could convert back to a critical access hospital. Those conversions are not necessarily easy or quick, and so you probably would not see that, but there is a process in place that could occur. Thank you.
Other questions? Assemblyman Gray asked mine, so we'll go ahead into testimony. We'll start with support in Carson City and Las Vegas. If you are here in support testimony on Assembly Bill 277, please come up to the desks. Remember to state your name for the record. You may begin when you're ready.
Chair Peters, committee, thank you so much for giving us the opportunity to testify on this important bill. For the record, Isaac Tenorio with Strategy 360, today representing the Valley Health System of hospitals, which includes Desert View Hospital, a critical access hospital in Pahrump. We urge the committee to support this important piece of legislation. Our rural communities need the ability to provide these critical emergency crisis services, and we thank you for your time.
Thank you. Please go ahead. Remember to state your name.
Good afternoon, Chair Peters and members of the committee. Amy Sjogren with Black & Wadhams, representing the Nevada Hospital Association this afternoon. Hospitals, as you know, are facing many challenges in the current environment, especially our rural hospitals. And we need to provide them with every option available to preserve healthcare services and the communities that they serve. Thank you.
Chair Peters, members of the committee, Ted Owens, Executive Director of Governance for the Incline Village Community Hospital, which is a small 4-bed critical access hospital. The importance of this designation, just a nuance, is the requalification as a critical access hospital can be challenging for small rural hospitals. One of those situations might be, in our case, if we do not have 2 patients in 2 of our 4 beds on the day of the survey, our designation may be at issue. So this designation is important because it gives some rural hospitals the ability to use this designation, which more accurately reflects how they operate anyway. So they may stay as a critical access hospital, or they may choose. The other benefit, of course, is maintenance of the reimbursement rates. Medicare, Medicaid, very important to rural hospitals. It helps them stay alive financially, quite frankly. So I came down today to urge strong support on AB 277. Thank you very much.
Thank you. Please go ahead.
Good afternoon, Chair, members of the committee. My name is Fran Almaraz, and I am the president of the Nevada Silver-Haired Legislative Forum. And on behalf of that forum and the many, many seniors throughout the state that we serve, I am strongly in support of this bill, and I ask you to please move it forward. Thank you.
You please go ahead.
For the record, my name is Mark Ellis. I'm President of Communication Workers of America, Local 9413. And on behalf of many of my members who work in the rurals, including myself, we are in strong support of this bill.
Thank you. Please go ahead.
Madam Chair Peters and committee members, my name is Alfonso Lopez. I represent the sheet metal and air rail transportation workers, and we also are in full support of AB 277. Thank you.
Thank you. Seeing no one else coming up to the table in Carson City and no one at the table in Las Vegas in support testimony, we will move to the phones. BPS, is there anyone on the public line for support testimony on Assembly Bill 277?
To testify in support of Assembly Bill 277, please press star 9 to take your place in the queue. Caller, please press star 6 to unmute your phone.
Good afternoon, Chairman Peters and committee. My name is Sue Bird, S-U-E-B-I-R-D. Living in the rurals, it is very important to keep our rural clinics open. I had an incident several years ago that I had a terrible reaction to a vaccination for pneumonia, and my arm swelled and my hands constricted into almost a ball. When I called Renown to have to run to Reno, I live in Fernley, they told me to get there as soon as I could. But if I stopped breathing along the way, to get an ambulance. Well, if you're familiar with I-80, there'd be no way for an ambulance to find you. So we need these rural hospitals for emergencies, not only for cost savings, but to save lives. Thank you, and please support this bill.
Thank you so much. Next caller, please.
Caller with the last numbers of 788, you may begin.
Good afternoon, Chairwoman Peters and members of the committee. For the record, my name is Rita Weishar. I'm with the Nevada Alliance for Retired Americans, and I am here in full support of AB 277 and urge the committee to support it as well. Thank you.
Thank you. Next caller, please.
If you have recently joined and would like to testify in support of Assembly Bill 277, please press star 9 to take your place in the queue. Chair, there are no other callers to testify in support at this time.
Thank you so much. We'll go ahead and move into opposition testimony. Is there anyone who would like to provide opposition testimony on Assembly Bill 277 in our physical locations here in Carson City or Las Vegas? Seeing no one approaching the desks, BPS, would you check the public line for opposition testimony on Assembly Bill 277?
To testify in opposition to Assembly Bill 277, please press star 9 to take your place in the queue. Chair, there are no callers to testify in opposition at this time.
Thank you so much. We'll move into neutral testimony in Carson City and Las Vegas. Is there anyone who'd like to provide neutral testimony? Please come up to the desk. Hello, Dr. Cole. Please remember to state your name for the record.
You already did. Barry Cole, Barrycole. I think this is fascinating. I just don't feel like I have all the details. And what troubles me, and I'm not in opposition, is that I used to be an emergency room doctor in a little town that was like in between two freeways, so all kinds of trauma came to me. When I drive from here to Las Vegas, I get into a panic when I clear Hawthorne and I'm approaching Tonopah Goldfield, and I'm thinking there's no more medical care until I get to Las Vegas. To operate one of these, and I'm looking at the fact sheets, what I don't understand is what equipment needs will there be? Who's going to be staffing this facility? To be open 24/7 and to be able to really provide emergency care will require at a minimum an X-ray unit of some kind, a CT scanner of some kind. You don't need an MRI, but you need a lab, and you need lab techs to run the tests during the night, during the day. We'll need nurses and at least, I would think, a physician or a almost like a nurse practitioner who's really trained in emergency medicine. So while I appreciate AB 277 for its way to save rural health care, and I know, having kept a hospital open with a geropsych unit, how critical this can be, I'm not sure who's regulating this, if this will be under Joint Commission or other accreditation standards. But emergency rooms are very good for hospitals to help them kind of make their bottom line. At the same time, they require a fair amount of equipment and around-the-clock staffing that will have to be considered. And that's the part that leaves me kind of neutral. I wish I understood more of this than the basic fact sheet, and maybe at the end we can have the sponsors come up and just fill in a couple details. My perspective.
Thank you so much. I think that is one of the complications of how we bifurcate some of the information available through the fiscal notes and the policy committee. There's a fiscal note from the Division of Public and Behavioral Health for that licensing process. So they would develop those licensures, but that will be discussed and in detail in the fiscal committee. Are there other folks who'd like to provide neutral testimony on the bill? Seeing none in Carson or Las Vegas, BPS, is there anyone on the phone line who'd like to provide neutral testimony on Assembly Bill 277?
To testify in neutral for Assembly Bill 277, please press star 9 to take your place in the queue. Chair, there are no callers to testify in neutral at this time.
Thank you so much. I would invite the bill sponsor for closing remarks.
Assemblyman Koenig for the record. I have some written concluding remarks, but I think I'm in the running for the shortest hearing, so I just want to say this is good for my rural constituents, and this is good for the rural hospitals, and this is good for Nevada, so thank you.
Thank you so much for bringing the bill. We'll close the hearing on Assembly Bill 277, and we'll move on to Assembly Bill 281. Oh, I'm so sorry. Before I close the hearing, if we can reopen the notes on this, Assemblyman Gray had a comment he wanted to make.
Thank you, Madam Chair. Again, I just wanted to thank Assemblyman Koenig and Rural Hospitals, Blaine Osborne. This bill, and I'm sure you know this, ma'am, rural hospitals, the rural communities were in dire straits when it comes to medical care and the availability. And I would just really urge you and this committee to move this along as quickly as possible to a work session so we can get this through, because this is something we really need to do to stabilize healthcare in our communities. Thank you.
Thank you for those comments, and I would again ask that those be included in the minutes within that that bill hearing. We'll go ahead and close the hearing on Assembly Bill 277 and move on to Assembly Bill 281. We'll open that hearing. Assembly Bill 281 revises provisions governing senior living facilities. We have our very own Assemblywoman Gorlow in attendance to present this bill. I will let them get situated before we begin. Not enough seats at our table today. Welcome, thanks. Please remember to state your name for the record when you speak. You may begin when you're ready.
Thank you very much, Chair Peters. For the record, I am Michelle Gorlow, representing Assembly District 35, and today I am not here talking about maternal child health. However, we will continue the conversation discussing senior living facilities. So with me today is Randy Soltero and Chris, I'm sorry, Rook. He's here too, and testifying in neutral. I'm sorry, I wasn't sure he was going to be at the table with me. But in neutral, we have in Las Vegas, Dr. Brian Labus. So this bill sets forth specific provisions outlining the assessment and standards of air filtration systems in senior living facilities to ensure the best possible air quality for seniors in Nevada. There are many factors that can impact the air quality in senior living facilities. One we most be familiar with is COVID, but that's not the only airborne concern. There's also tuberculosis, meningitis, measles, and the flu, to name a few. And there are also environmental factors that can affect air quality in senior living facilities. We might remember that fires that cause so much smoke and pollution in the air. Wildfire smoke is comprised of a mixture of gases, pollutants including carbon monoxide, hazardous air pollutants which include polycyclic aromatic hydrocarbons, and particle pollution. Particle pollution represents a main component of wildfire smoke and the principal public health threat. Individuals at greater risk of health effects from wildfire smoke include those with cardiovascular or respiratory disease and older adults, as it can increase incidence of asthma, emphysema, chronic lung disease, and other health concerns. The pandemic heightened the need for high-quality air filtration systems to help minimize the impact of airborne diseases and pollution, as we saw disproportionate numbers of cases in these facilities. By improving the requirements of air filtration systems in senior living facilities, we not only improve the air they breathe, but we can also improve seniors' health and quality of life while living in these facilities. And to talk more about this legislation, I will turn it over to Mr. Soltero.
Thank you, Assemblywoman. And Mr. Soltero, yes, please proceed.
Thank you, Mr. Vice Chair and members of the committee. Thank you so much. For the record, Randy Soltero, today working with this group of experts that know much more about this stuff than I do, but try to get to the gist of this bill. First, I would like for you to hear from Alfonso Lopez, representing the Sheet Metal Workers Union, who actually were the folks that asked to bring this bill forward.
Vice Chair, committee members, my name is Alfonso Lopez. I represent the sheet metal and air rail transportation workers of Local 88. In 2021, legislation was passed for indoor air quality for the Clark County School District. We feel it's time, very important to now pass this for senior living facilities. I'd like to also assure you that the workforce is in place already. We have well over 50 people that are capable of doing these inspections, highly trained, certified as well, ready to do this work. I would now like to introduce to you Chris Rook. He represents the National Energy Management Institute. He is the expert witness when it comes to answering any technical questions pertaining to this bill. Thank you very much.
Thank you, Mr. Lopez, and please proceed with your name and spelling it. Thanks.
Sure. Christopher Rook, R-U-C-H. I'm the Director of Education for the National Energy Management Institute. Vice Chair, and members of the community. Thank you for the opportunity to speak in front of you. Most of my career was happily spent on the roofs, making sure that systems worked the way that they were supposed to, the ventilation systems. Unfortunately, I can tell you that many times I didn't see them working the way they were supposed to. And given the concerns that I have, like all of us, for the members of our community, I felt it was important for me to come here and talk about what I see and the importance of this. So, indoor air quality should be verified in senior living facilities. Now, this is a proactive way to identify and address vulnerabilities in these facilities, thereby safeguarding health and well-being of quality of life of its residents. Now, we do know that our elderly residents' health is influenced by indoor air quality. Some of the considerations for that: our elderly residents have a greater predisposition to respiratory infections. Elderly residents commonly have underlying chronic medical conditions and reduced immune deficiencies that may make them more susceptible to the effects of air pollutants. We also know that residents with reduced mobility spend approximately 95% of their time inside, and that the CDC put out a study that showed that 57% of all sicknesses can be attributed to poor ventilation. So with that said, elderly residents, along with children, are the two most vulnerable groups in regards to poor indoor air quality. Now, Nevada has done a great job with the schools and taken great steps towards making sure that the children in the schools and the indoor air quality is addressed. What I looked at this bill for was a pathway to improve the indoor air quality in senior living facilities. Now, one of the most effective methods to reduce the concentration of pollutants and maintain good indoor air quality is adequately ventilating and filtering indoor spaces. So the ventilation verification process that's within this bill, and this will get to the fundamentals, and this is what I can answer for all of you, is the very first part in Section 17. You're looking at a physical verification by technicians that are skilled, trained, and certified and know what they're doing that come to this. They're looking to see are the filters installed, because if you have spaces and gaps between the filters, it doesn't really matter the MERV rating of the filter, or the efficiency of that, I should say. You want to see if the outside air, is it actually bringing in the right amount? Has the room use changed from what it was? Are the components working? This is both for energy efficiency and for indoor air quality. These are great components, but if they don't work just like a part of your car, it doesn't do you much good. You're looking at inlets and outlets. You see them around this room. If you don't have the air distribution proper, you're not going to get the benefits no matter how great that unit's working on the roof. You're looking to see has basic maintenance been done in regards to ventilation. And like I said, unfortunately, as a technician that spent a lot of time on a lot of roofs, a lot of that maintenance is not done. Are the control sequences set? It was very common for me in the field to find that a unit was set to be going off and on during the day like your house. But for a building like this with this many people in it, you need the system running all the time. It doesn't have to be heating or cooling, just bringing in fresh air and filtering. And lastly, a CO2 sensor is an indicator of if there's a sudden problem with the ventilation system. I can check to make sure the ventilation system's working well today, and I would be glad to work with your team and be on the roof today working on it, I assure you. Problem is, I don't know what's going to happen tomorrow. It's a mechanical device, and just like your washing machine or anything else, these things break. Then you move into an HVAC assessment report that technician delivers, and they bring it to the mechanical engineer. This allows the mechanical engineer to make a lot less assumptions when they're trying to figure out what to do. They can then meet with the senior living facility and triage what needs to be repaired, what can be fixed, what can just simply be adjusted, so that way they can meet the indoor air quality and energy efficiency goals. And lastly, you would see corrective actions that would come out, and then a final ventilation verification report. So with that, I'm always open to any questions to all of you, and thank you very much for your time.
Thank you.
Madam Chair, members of the committee, again, Randy Saltero for the record. I will take you through, if you will turn your attention to the quite lengthy amendment that we'll go through. We applaud the efforts of our Legislative Counsel Bureau here in the building and the hard work that they did on the original draft. We did add, as Mr. Rook was talking about, we have added some amendments that will better clarify, and these are the amendments that I would like to take you through the steps on. First of all, in that, again, the large piece. You actually have two amendments, one from us and one from, that I'll talk about, from Nevada Hand. I will get that to when we get to that section.
I'm sorry, we only have one amendment in our exhibits. Is the second one brand new? Do we have, does everyone have one? I don't see one on my desk.
Is that the Nevada Hand one? Do you have the other one?
Okay. I buried mine. Thank you. We all have a physical copy at our desk. If you do not, we will work with staff to get that uploaded onto Nellis. But if you do not have one, we can make sure you get one. All right, please go ahead. Thank you.
Thank you. Again, for the record, Randy Saltero. Going to the changes of the from the original bill, Section 4, 5, 6, 7, 8. All those are definitions that were added in to the bill to make it more clarified of what those things are, including that also Section 9 and Section 10 would be the same. You see there are some items that were struck from the original language, again, to kind of streamline this and to make it more defined. Section 11, qualified testing personnel means either of the following. Those are the, again, the proper certifications that should be held for a person who is doing testing in these facilities. Then here we get to, I like to say the meat and potatoes here. Section 12, senior living facility means any facility that receives any federal funding from Medicare, Medicaid, or other federal health care program in which provides living assistance and related care to a resident of the facility who is in an aged or infirm person, including, without limitation, a facility for intermediate care, facility or skilled nursing, residential facility, or group or home for individual resident care. The reason I read that out is we have been approached by another organization that does care for adolescents who are need intensive care, who are infirmed persons, and we believe that we will ask LCB to review that. If this definition, even though it says senior living facility, if it would then take in those folks as well. Section 13, skilled and trade workforce, the amendment for the applicable occupation is added to the original language. Section 14, tab means testing, adjusting, and balancing, a definition. Section 15, the new number 15, from the original bill. This is everything that was brought originally by LCB. Legislature finds and declares that all those parts there and through the next several pages saying what this legislature finds is appropriate. Through the renumbered now renumbered section 16. This is very important, and this is what we anticipate there'll be questions on. To the extent, and this is important, to the extent that money is available, the administrator of a senior living facility shall ensure that the senior living facility is equipped with a functional ventilation system and is tested, adjusted, and if necessary or cost effective, repaired, upgraded, or replaced to increase efficiency and performance. Money shall be considered available if the senior living facility, A, reserves federal or state money, allocates such money to equip the senior living facility with a functional ventilation system, B, as condition of receiving federal or state money, is required to ensure the senior living facility is equipped with a functional ventilation system or approve the ventilation system of the indoor air quality of the senior living facility. I say that it's important because that was what the biggest questions we were being asked is, who pays for this? And what part of it is paid for? So there is, and actually we're going to have Mr. Abril here to, once I get through this amendment, he can address that funding part of it. He will talk about that, how that federal money is. Similar to the bill that we did in 2021 for the schools, it was federal CARES and ERISA funds that were used at that time, but I'll leave that to Mr. Abril to talk about that at the appropriate time. We do have an amendment from Nevada Hand. I believe you have that. Actually, it goes back to in section 16. It would add after A and B, it would add then a new section proposal C, facilities that qualify under NRS 319147 that may utilize the federal funding pursuant to section 16A to upgrade and maintain ventilation systems. There's someone here from Nevada Hand that will come and testify onto the reasonings for those purposes. And then I'll talk about their other amendment that we are happy to adopt. Moving along after section 2 of, section 16, sub 2, adding the words or cause such persons to be contracted to perform a ventilation verification assessment. Again, this is language that was an interest of folks who would be qualified to do this work. Section 17, ventilation verification assessments, kind of describes what what the administrator of the facility would be tasked to do as far as documentation, the testing, the physical measurements, all the different things that would be required. You'll see down in Section G, the verification of the unit operation, required maintenance is performed in accordance with ASHRAE standards. Again, Mr. Rook is here to answer any of those technical questions. Again, the next page, it continues on all the types of things that have to happen in order to make sure that the system is properly installed and operating. Again, Mr. Root's, I almost said problem, but his expertise, if you have any questions on that, through Section 19, the same. I will say, continuing through there, it's a big amendment, I know. Lastly, Section 21, the effective date, and then from Nevada Hand, a new Section 22, ask for your acceptance of this amendment as well. The program section sunsets when the federal funding is no longer available. The rest of that language from the rest of the bill has been struck. We are prepared with any questions. Dr. Labus is in Southern Nevada. You heard from him earlier on the first bill. He has said he would be here available for any questions that you may have. If I may, prior to any questions, before it's even asked, I'll have Mr. Abril talk about the funding piece, which was a big question that we had from stakeholders, and we want to make sure that that's addressed on the record.
Thank you, Randy. Madam Chair, committee members, my name is Dion Abril, last name spelling A-B-R-I-L. The question was identified. We do have identified few federal funding options. Currently, we believe the state of Nevada's Governor's Office of Energy is in the process of receiving funds from the federal bipartisan infrastructure law and the Inflation Reduction Act of 2022. Another option that we've identified is the state energy program. These funds can be used to perform HVAC upgrades and retrofits to buildings, including facilities talked about in this bill. We're not aware of any other funds at this moment, but we do have subject matter experts in DC through our international that we would be glad to come in and talk with the committee and go over all of the other bills or other funding options that we have. Thank you.
Thank you. That was going to be one of my questions, was the federal funding options. Sunsetting on federal funding available is an interesting way to address policy. So I think there's some conversation we could have around that piece. I have a couple questions from Assemblywoman Taylor, but she has to get out of here, so I'm going to ask her questions so we can get those on the record. You're welcome. So I'm going to start with the first question, and then it leads into the second question. Can you talk about some of the health impacts of poor indoor air quality? I think this is directed at
Dr. Labus.
Yes, Dr. Labus. Thank you.
This is a really broad sort of issue. Indoor air quality can be everything from the allergens that just kind of annoy you and cause allergy problems to things like particulate matter that can make their way into the house. When we see bad air days in the community, we know we see an increase in heart attacks. It can be infectious diseases, so things that stay in the air for extended periods of time, like measles, for example. The more air exchanges you have per hour in a space, the more reduction in those diseases you will see. It won't completely eliminate things. You're still going to be around people that can spread disease to other people, but by basically exchanging the air more frequently, it reduces the risk of all sorts of disease transmission. So we talked about Legionella earlier today, a properly maintained system. That's one disease that you won't see if things are running the way they should be, assuming it's not contaminated and everything's working properly, you won't be exposed to Legionella. There's all sorts of respiratory viruses. When COVID came out, a lot of the directions we gave to people were around how to handle air in their homes. We said things like open the windows and exchange the air more often, something that you can't do in large buildings frequently, and that's why we have to rely on the large HVAC systems to do that for us. And so it can really cover a lot of different things, all the way from minor annoyances to serious health problems. The difference between allergies and somebody who has an asthma attack, those can all be affected by the indoor air that is around you every single day.
Thank you for that response. The next question has to do specifically for residents of senior living facilities, and what are specifically the poor indoor air quality concerns for that demographic population or in those facilities?
For the record, Brian Labus. It's really the same things I talked about before, but we're talking about a high-risk population. So if you have a younger, healthier population exposed to the same things, the health effects are just going to be less than you would see with an older population with a lot of underlying health conditions. As we get older, we start to have more and more chronic conditions. Some of those are respiratory problems to begin with, things like COPD and emphysema. People just have more and more problems breathing as they get older, so even minor respiratory problems for a healthy person could be a serious issue for somebody who's much older. So it's really not that there are any different problems, it's that you have a much higher risk of disease if you're exposed when you're older, and typically the outcomes tend to be worse if you were older as well.
Thank you for those responses. Are there other questions from the committee? Oh, yep, Assemblywoman Newby, please go ahead.
Thank you, Madam Chairwoman, and thank you for the presentation on the bill. I don't recall what section it was, but I remember seeing the definition of a highly skilled workforce as 60% of the individuals attending or going through an apprenticeship program. Is that the standard definition within NRS, or is it different?
I can only speak to what I know from this state in the past is the bill that we talked about. I'm sorry. For the record, Christopher Rook, NEMI, Madam Chair, through Member Newby. So I can only speak to what I know from the past with this, is that this is the same language that I believe was used in the past bill for the schools doing the same thing, and this really has to do with making sure that you have the right people doing this work. Yes, ma'am.
Thank you for the question. Other questions from the committee? Seeing none, I think we're ready to go into testimony.
Madam Chair, if I may, if I may, thank you so much for this opportunity to present this. I do want to say that we've had a lot of folks come to us. We have been working with not just Nevada Hand, but some other organizations that had some concerns, and we are hoping that we have delivered on our promise to make sure that everybody has their opportunity to have their say and do what we can do to get this bill to the right place. So I'm hoping that we'll hear some folks today that in testimony that will reflect that. Thank you so much.
Thank you. We'll go ahead and open support testimony on Assembly Bill 281 in our physical locations and then go to the phone lines. If you are here in support of Assembly Bill 281, please come up to the desk and remember to state your name for the record, and you may begin when you're ready.
Greg Esposito, representing the Nevada State Pipe Trades. When I introduce myself to legislators, I share our mission statement, which is to protect the health of the nation. And this is definitely a bill that will go a long way towards doing so. So we are in full support, really appreciate the Assemblyman bringing it forward, and fully support the bill. Thank you.
Thank you. Please go ahead.
Good afternoon. Good afternoon, Madam Chair, members of the committee. Again, my name is Fran Almaraz. I am here today representing the Nevada Silver-Haired Legislative Forum for the seniors in this state. Seniors are the most vulnerable population. Many seniors have no choice except to live in a community building. Air quality is so very, very important. Many of them, have asthma, COPD, other infirmities, and the air they breathe is just so very, very important. I urge you to please think about this bill and please pass. Thank you.
Thank you. Please go ahead.
Matt Leiden, Business Manager, Plumbers and Pipe Fitters, Local 525, President of the Nevada Pipe Trades. We rise in support of this bill.
Thank you. Please go ahead.
For the record, my name is Mark Ellis, Communication Workers of America, Local 9413, and I guess I'm going for the trifecta because on behalf of my retirees, we are in full support of this bill.
Thank you. Please go ahead.
Thank you, Chair Peters and members of the committee. For the record, my name is Susie Martinez, and I'm the Executive Secretary Treasurer of the Nevada State AFL-CIO. Nevada seniors deserve living facilities that allow them to live with dignity and respect. We must also prioritize protecting workers in such facilities and ensure that their workplace conditions are up to par. This is a critical bill that would ensure good air quality in these facilities and ensure the safety of both residents and the workers that work in these. Additionally, we're facing a healthcare provider shortage, and we simply can't afford to risk the health of our workers. I would like to thank my former roomie, Assemblywoman Michelle Gorlo, for bringing this bill forward. I know that you guys are all excited that it's Friday, so I would like to say thank you to the unions, the people who brought you the weekends. Thank you very much.
Thank you. And yes, some of us are saying thank you. Others have to work tomorrow. Please go ahead when you're ready.
Kent Irvin, Nevada Faculty Alliance. Please support SB 281. Our main interest is in indoor air quality of our classrooms and lecture halls, but senior care facilities are obviously more critical because typically in my chemistry lecture, there's only one vulnerable senior. I would like to explain why carbon dioxide monitoring in this bill is so important. CO2 sensors are cheap, and it's an easy way to monitor ventilation. In this room right now, the CO2 level, according to my little sensor here, is 762 parts per million. The background level is 450 parts per million, and when the room was full, it was hovering around 800 parts per million. Why is it higher than outside? It's because we're all breathing out CO2. So unless we're bringing in outside air, the CO2 builds up in the room. This is very good, 800 parts per million from what I've read about ventilation. I'm not an expert in that, but from what I've read. And in the legislative building overall, it seems like ventilation is quite good, except maybe in the assembly chambers during a joint session. It builds up a little bit more. But why is that also important? Well, it's an easy way just to monitor if your system is working, but also, along with breathing out CO2, we are breathing out aerosol particles that, if one of us is sick, could contain coronavirus or other infectious particles. And so it's also a way to know, to ensure the safety of the indoor air quality that way. So just please support healthy indoor air.
I love when we get lectures in this committee. It's my favorite part. We have some of the smartest folks, I think, in this committee, although I'm probably biased. Is there anyone else oh, I see Las Vegas. We have someone in support, but if there's anyone else in Carson City, please come up to the table. Please go ahead when you're ready.
Good afternoon, Chairwoman Peterson and members of the committee. For the record, my name is Eduardo Zavala. I'm with the Bricklayers Union in Nevada. I strongly urge the committee to vote in favor of Assembly Bill 281.
Thank you for your testimony. Seeing no one else at the tables in our physical location, I'd ask BPS to check the phone lines for support testimony on Assembly Bill 281.
To testify in support of Assembly Bill 281, please press star 9 to take your place in the queue.
Good afternoon, Chairwoman Peters and members of the committee. For the record, Liz Sorensen, President of the Nevada State AFL-CIO, and I am in support of AB 281, and I urge this committee to vote in favor of it as well. Thank you so much for your time.
Thank you, Ms. Sorensen. Next caller, please.
Caller with the last number 026, please press star 6 to unmute your phone. Again, caller with the last number 026, please press star 6 to unmute your phone.
Good afternoon, Chairwoman Peters and the members of the committee. Thank you for letting me give my testimony today. My name is Sue Bird, S-U-E-B-I-R-D. I am strongly in support of AB 281. Being a senior, I know that if I don't get up and move, my life is shortened. And not being able to breathe, catching a disease in my lungs, can shorten my life dramatically. This is very important to any of us that should be going into a nursing home, not only for ourselves, but for our nurses. We know that our medical field is tired and has worked very hard, and they need all the help they can get. So please, I urge you, please support AB 281, and thank you again, and have a nice weekend. Bye.
Thank you, Ms. Bird. Next caller, please.
Good afternoon, Chair and members of the committee. My name is Paul Catha, that's spelled C-A-T-H-A, and I represent the Culinary Workers Union Local 226. The Culinary Union supports Assembly Bill 281, and we urge the committee to support and pass it as well. Thank you.
Thank you, Mr. Catha. Next caller, please.
Caller, you may begin.
BPS, did we lose that caller?
Yes, Chair. Would you like to move on?
Yes, please.
Good afternoon, Madam Chair and members of the committee. My name is Marlene Lockard, representing SEIU 1107, and we are in full support of this bill. Thank you.
Yes, Chair.
Thank you. Next caller, please.
Caller with the last digits 888, please press star 6 to unmute your phone. You may begin.
My name is Cassie Preston, and as a senior, I am in full support of this Bill 281, and I strongly urge the committee to pass it. Thank you so much. Have a great weekend. Bye-bye.
Thank you for your testimony. Next caller, please.
Good afternoon, Chair and members of the committee. For the record, my name is Ariel Edwards, ARIELLE-EDWARDS, Director of Government Relations for Nevada Hand. My apologies for not being there in person. Nevada Hand is the state's largest affordable housing developer and builder and a nonprofit organization. Nevada Hand provides the only 2 affordable assisted living communities in the state of Nevada. We provide 180 apartment homes for seniors in need of assisted living. We are in support of the amended version of AB 281. At this time, our assisted living communities are facing sustainability challenges, and we are hoping to have these challenges addressed this legislative session to continue serving our seniors. And this amended language in AB 281 will make this optional for us to take the grant dollars, as well as allow us to access the funds later once we are able to figure out the cost of maintenance in light of our sustainability challenges. The sunset part is also to ensure that when the federal program monies are gone, the statute does not require assisted living facilities to upgrade systems without federal support. So we would like to thank the bill sponsor, Assemblywoman Gorlow, and the stakeholders for working with us on this bill and accepting our amendment. We thank you all for your leadership. Thank you so much.
Thank you. Next caller, please.
Chair, there are no other callers to testify in support at this time.
Thank you. We were in support testimony. We'll move into opposition testimony. Is there anyone who would like to provide opposition testimony on Assembly Bill 281 here in Carson City or in Las Vegas? I can't see Las Vegas, so please make your way up to the table if you are here in opposition. Please remember to state your name for the record. We'll begin here in Carson City. You may begin.
Thank you, Madam Chair, members of the committee. Joan Hall, representing Nevada Rural Hospital Partners. I'm here today in opposition, but willing to work with the sponsor and Mr. Soltero Moore on definitions. First of all, the definition where it talks about if you receive federal money, all skilled nursing and intermediate care facilities receive federal and state money by means of Medicare and Medicaid. And so then when it later talks about receiving federal or state money in Section 16, I think it needs to be clarified that that's grant funds or other funds, not the federal and state money that we receive. With that, I think the bill establishes increased requirements for ventilation and filtration systems. And so if this doesn't have a sunset, as it's stated in the proposed Hand Amendment, that could impose a huge issue for current facilities to meet new regulations. So we need a longer period of time, especially if we can't use those grants. I think my members are unaware of these 2 grants, so looking forward to finding more about them.
Thank you. Please go ahead.
Thank you, Madam Chair and committee members. Brian Evans, representing the Nevada Healthcare Association. We just like to thank the sponsor for taking time to meet with us. I echo a lot of the comments of Ms. Hall. We just have some concerns on the mandate and the funding sources, and then just the ongoing maintenance and things that could be if there's not the sunset as well. But we'll continue to work with the sponsor to address those concerns. Thank you.
Thank you. Are there other folks in opposition here in the physical location? Not seeing any. in Las Vegas or Carson City, we'll go ahead and move to the phones. BPS, is there anyone on the public line who'd like to provide opposition testimony on Assembly Bill 281?
To testify in opposition to Assembly Bill 281, please press star 9 to take your place in the queue. Chair, there are no callers to testify in opposition at this time.
Thank you. We'll move on to neutral testimony. Is there anyone in Carson City who'd like to provide neutral testimony? Seeing none, is there anyone in Las Vegas who'd like to provide neutral testimony? Seeing none, BPS, would you check the public line for neutral testimony on Assembly Bill 281?
To testify in neutral for Assembly Bill 281, please press star 9 to take your place in the queue. Chair, there are no callers to testify in neutral at this time.
Thank you. I'd like to invite the bill sponsor back up for closing remarks if you'd like.
Thank you. Thank you very much, Chair Peters. For the record, Michelle Gorlow, representing Assembly District 35. Appreciate the time of you and the committee to listen to Assembly Bill 281. And we are still working with many of the stakeholders and be willing to discuss the funding source and how this would be paid for as well. So thank you very much.
Thank you so much. With that, we'll close the hearing on Assembly Bill 281, and that brings us to the last item on our agenda today, which is public comment. We will start public comment here in Carson City and Las Vegas, and then we'll move to the phones. Is there anyone in Carson City who'd like to provide public comment for today? Seeing no one. Is there anyone in Las Vegas who'd like to provide public comment today? Seeing none. BPS, would you check the public line for public comment today?
If you would like to provide public comment, please press star 9 to take your place in the queue. Chair, there are no callers choosing to provide public comment at this time.
Thank you so much. We'll go ahead and close public comment, and that brings us to the end of our day. We will have committee on Monday, but other than that, if there's no further discussion from members, we are adjourned.